I'm Ashley Woods, a physician here at the Maxwell Clinic, and I am doing a webinar today on bone health. So welcome. I want to tell you why I wanted to talk about this today is because this is a very personal topic for me because I'm at increased risk for bone loss or osteopenia, osteoporosis. I have a very strong family history. My mom has osteoporosis pretty significantly. My dad has not been tested, but I think he probably has because he has poor posture and his height has been affected. So I suspect he also has osteoporosis. And my father-in-law in the last year of his life fell just in his home, just on carpet, and had a spinal compression fracture. It affects a lot of people. And many of my patients have osteopenia or osteoporosis, and many of them do not want to take medications. And so because of potential side effects, and we're not going into meds in any kind of detail today because I'm talking more about bone health and what you can do beyond medications. So let's get started. Okay, our goals for our time together are to think more about our bone health. Most people don't think about their bones, and to feel motivated to take action and to know why you're taking action and to know what to do exercise-wise, nutrition-wise, supplement-wise, and to feel empowered with those actions. So bones are a bit of a dry topic. They're not very sexy. Most people don't even think about bones. They're not aesthetic. You don't go and get Botox for your bones. You don't brush your bones every night like you brush your teeth every night. We just kind of ride around on them all day as our main structure, and we just don't even think about them. And they don't usually make headlines like cardiovascular disease or cancer. But we need to think about them because we are all at risk for an osteoporotic fracture as we age. And I'm throwing around terms that I will define later, but osteoporosis is significant loss of bone density. Osteopenia is on that continuum, and I have a slide about that later, so we'll dig in a little bit there. But unless you have arthritis, which is not what we're talking about today, or osteoporosis or osteopenia, you probably don't think about your bones much at all. Why should we care? I mean, most people think, oh, old white women get osteoporosis. Yeah, well, men get it too. And it's not just white women, it's all races, although white women are at increased risk. And so when you look at this picture, you think, well, I don't want to look at like the woman skeleton on the right, and she has a dowager hump, which is the hunched back, and you do see that from time to time. Here's some other things that you probably don't want. You don't want the dowager's hump. You don't want to have to end up using a walker, a wheelchair, end up in a nursing home because you fractured something, to be in pain from a vertebral or hip fracture or any fracture for that matter, have a loss of independence, which is a outcome from having a fracture or just having osteoporosis. People become fearful, and that's next on the list of doing things. I mean, snow skiing, water skiing, activities, playing football in the yard with your kids, things that you normally would enjoy doing, people become fearful of doing that. And so they stop doing those things because they go, well, I have this osteoporosis and I don't want to break a hip, so I'm not going to do those activities. So fear plays a role here too. Loss of height. I am a whopping 5'4", and I do not want to get shorter. So most people don't. And then again, a diagnosis of osteoporosis or osteopenia. So this is a striking slide. Where do you want to be? You want to be like the gentleman on the left or the couple on the right? What does your Maxwell look like? So why should I care about this? Well, it's estimated worldwide that 1 in 3 women and 1 in 5 men over the age of 50 will experience an osteoporosis fracture in their remaining lifetime. According to the U.S. Surgeon General, over 10 million persons over the age of 50 have osteoporosis, and over 43.3 million have low bone density, also known as osteopenia. In persons over the age of 60, falling is a major cause of accidental injury. Accidental death is the third leading cause of death. That seems sort of dramatic because cancer and heart disease are up there, but that is where this factors in. The average mortality after a hip fracture is 25% within a year. So if you fall, and I'm not just being dramatic here, if you fall and break a hip, your chances of, and my chances of being in a nursing home and subsequently dying in that nursing home within a year are about 25%. Those are not good odds. That's pretty staggering data. And men, you are not off the hook with this. Men get osteoporosis as well. Your risk is not as high as women, and estrogen plays a role, and we're going to talk about that. But to put this in perspective, I saw a fact, it's estimated that the residual lifetime risk of experiencing an osteoporotic fracture for men over the age of 50 is higher than a lifetime risk of developing prostate cancer, which is 11.3%. So that's another reason we should all care. And then parents, if you're listening to this and you have kids, we teach our kids to brush their teeth because we want them to keep them. And how to care for our bones should be equally as important. I mean, we have them wear helmets when they ride bikes so they don't break a bone. But why not just when we talk about teeth, why not talk about bones? Childhood and adolescence is the time that you're building your bone. And it's critical to optimize your peak bone mass during this time. So it starts in childhood. So nobody is too young to listen to or to know these facts and to listen to this webinar. So we're all chronologically getting older, but I strongly believe how quickly we biologically age is up to us. So let's talk about bones for a minute. And we're going to get kind of sciencey here, so I'll try not to dig in too deep, but I think it's important to understand that bones are a living tissue. They support our muscles and protect our vital organs, and most people know that, but they are also the main reservoir for minerals, primarily calcium and phosphorus in our body. There's other minerals, and we'll talk about those. But calcium is vital for lots of functions in your body. Think your heart beating, your muscles contracting, sending nerve signals to your brain, blood clotting, teeth. Calcium is important, has lots of functions. And if you're not getting enough calcium in your diet, or there's problems in your gut and you can't absorb calcium, guess where that comes from? It comes from your big reservoir, which is bones. So there's a lot of reasons for people to be calcium deficient. And when you're trying to build bones, that's critical. You don't want to take from your reservoir. So we're going to talk a little bit about some bone basics. So bones, what are they made of? They're made of collagen, which is a protein matrix. And that collagen organic structure is mineralized with lots of major minerals, primarily calcium and phosphorus, which form an insoluble salt called hydroxyapatite crystals. But there's also magnesium, boron, zinc that also play a role. There's two types of bone, and I kind of like to describe them as sort of a Q-tip as a way of thinking of them. There's cortical and trabecular. Cortical bone is the shaft of the Q-tip or the shaft of your leg or your femur, and the trabecular bone are the sort of the fluffy ends of the Q-tip. Trabecular bone is what is in your vertebral bodies or your spine bones, and cortical bones are in your long bones. And then you have the bone marrow, which resides within the cortical bone, and it's primarily composed of blood products, red cells, white cells. Anyway, and then you think about, well, on a cellular level, there's those cells, those bone cells are called osteocytes. And there's two types of osteocytes, osteoblast and osteoclast. And I remember this in medical school because I was like, blast is for building. So the osteoblast help build bones and osteoclast help tear down bones. And it's important to have both because your body is constantly remodeling all your bone. 2.5% of your skeleton is under construction or being remodeled at any time. They're like little tiny construction sites, if you want to think about it that way. The osteoclastic phase is about 3 to 5 weeks, and the osteoblastic phase is 3 to 5 months to complete. And they talk to each other. The osteoblast signal the osteoclast, hey, come in. We're detecting a strain. We're going to build some new bone. We need to clear out the old, less good bone. And your bone is constantly turning over all the time. But that communication can get out of sync. There's signaling molecules that create this symphony or the instructions at the construction site. These signaling molecules tell the osteoclast to begin the process of clearing out the damaged bone when there's microfractures that you don't even know about, and it stimulates the osteoblast to build healthy bones. But you got to have the raw materials to build the healthy bones, and that's where nutrition comes in. So these cells work close together, and then there's quality control issues. And so we'll talk more about that a little bit later. Hormones play a role here because hormones, primarily estrogen, is a major signaling factor to the osteoblast. And our most prolific time of bone growth, again, is in childhood. Obviously, when you're a baby, your skeleton grows because you grow into an adult size frame. But the time where we increase that density and quality is from age about 9, 10, sometimes 8 to about age 20. That's when we're building bone density. That is a critical time. And here's the graph. It shows your bone mass increases, and you can see how it's a steep slope up until about age 20. And that's when you're really building bone. And we're going to talk about what kids need to be doing to really reach their full genetic potential. If they're not getting adequate exercise, if they're not eating the right diets, doing things that create oxidative stress. We'll talk about how these play out. They can actually be hindering and not reaching their full genetic potential. Therefore, they're starting out in the hole. They've got less bone to lose. And then, of course, this slide does kind of speak to the menopause piece here, where specifically in women, you really see a sharp decline, and where that starts is different for different women. Here on the slide, it's 50 because that's an average, but I have lots of folks that hit menopause before that for surgical or natural reasons. So healthy bone is on a continuum. You start with a healthy bone, then it becomes osteopenia, then it becomes osteoporosis. And this is all measured. It's measured by a test called a DEXA scan, which stands for dual energy X-ray absorptiometry. And basically it's painless, it's quick, it takes 10 minutes. There is very, very, very minimal radiation, less than a chest X-ray. And it's not terribly expensive. It is, it's an important test to measure, and we'll talk about what kind of data it gives you. Osteopenia is about a 10% bone mineral density loss, and osteoporosis is about 25%, but there's actual numbers that are more specific, and we'll talk about it. But again, the point of this is that it is a continuum, and where we are all on this continuum depends on lots and lots of different factors. Family history, genetics plays about a 50% role here. It accounts for about 50% of the risk. So if you have a family member with osteoporosis or a random fracture that just fell that occurred because they coughed too hard or they lift the trash bag out of the rollout garbage can. That's abnormal. They probably have osteoporosis and should be checked. Smoking dramatically increases your bone loss at any time that you have smoked, and it's actually worse for kids or preteens that are experimenting with smoking. That's really quite detrimental. Low body mass. So it's good to not be overweight. Obviously, you don't want extra fat mass just to protect your bones. But ironically, people that are overweight tend to have less osteoporosis because they're doing more sort of weight-bearing exercise every day. But when an overweight person loses significant amount of weight, that's awesome, except for they're also losing skeletal muscle mass. And so you really have to work hard to maintain your skeletal muscle mass best you can while you're losing weight, because you lose bone too. That's a problem. Certain medications, classically corticosteroids. So people that have to take steroids for things like asthma or inflammatory diseases long-term, that's a risk for osteoporosis. PPIs, which are proton pump inhibitors that lower your stomach acid, that is a risk for osteoporosis because you may be absorbing less nutrients. So there is some data on that, and I didn't list it on here, but I think some anti-seizure medications can also be a risk factor. Excessive alcohol intake. Age, obviously, sex, female, race. African American folks have a less of a risk, but they still are at risk too, as are Mexican American, but Caucasians are actually at a higher risk. I don't really know why that is, but that is what plays out in the data. Menopause. So this is a big one. And this is, I think, the reason that women are at such increased risk is because when they hit menopause, whether it's surgical because you had a hysterectomy or other medication induced because you've had breast cancer or something happening, or just loss of estrogen naturally, your estrogen level plummets. Well, estrogen is one of those hormones that helps with cell signaling, and the cell signaling is what tells, remember the orchestra and the construction site and all that, it tells the osteoblasts to kick up their activity. I put on here sort of as a joke, menopause. Again, men, not leaving you out here, low testosterone. Men's testosterone can decline. There's lots of reasons that happens inappropriately earlier. This is not the point of this talk, but estrogen is made from testosterone, and so in the body, in men, in women, and men do have estrogen. And so if you have low T, those men also have low estrogen, and that can be a risk factor. Again, inflammatory diseases, because they frequently require steroids. Diabetes, interestingly, is a risk factor for osteoporosis. Also, I didn't put it on here, but if you have thyroid disease and you are on thyroid replacement, you want to make sure you're threading the needle. You are not symptomatic. Your thyroid is replaced. You feel awesome, but you're not over replaced, because over replacement of thyroid hormone causes bone loss. So that can be a little tricky. Oxidative stress. Now, this was not something I learned in medical school. This was something I learned since my training with functional medicine, is that oxidative stress is a major player in bone loss. And you wouldn't know that. But the more inflammatory your diet is, the higher stress level you have, the more you are in a catabolic state, meaning you're in a state of breakdown instead of a state of repair, anabolic. That plays a huge role. And so even if you're not in menopause and you don't have a family history, I have people that come in and I'm concerned that they may already be losing bone due to some of these risk factors, or because they're so inflamed and have been for years. So we work on that. Malnutrition, malabsorption, maldigestion. I had a patient that a long time ago in her late 20s, and she already had osteoporosis. She had not taken steroids. She did not know her family history, so I suspect that that played a role, but she had food inadequacy as a child, and a lot of stress in her life, and she already had osteoporosis in her 20s. And so that speaks to that early building of bone and nutrition in the formative years. If you have problems digesting and absorbing your nutrients, well, guess where some of those minerals are going to come from? Remember, bone reservoir. They're going to come from the bone unless you are replacing them. So making sure your gut is in order is huge. Sedentary lifestyle. Activity very much affects bone density. So people that are more active and have more muscle mass have better bone health. I always tell my patients, for bone health, women, you need, and I'm sorry, men, I'm not leaving you out here, but women tend to not lift weights. Classically, more are now, and that's awesome. But you need to be doing weight-bearing exercises, meaning weight training, at least twice a week as a minimum. We'll talk more about that in a minute. But being sedentary is not helpful because it's that stress on the bone from the muscle pulling, sending signals saying, hey, we need more support here, creating osteoblast signals. And then again, not reaching your peak skeletal growth in youth. So how do you know? How do you know where you are on that continuum? Well, there's a DEXA scan, which we talked about briefly before. It's the gold standard of bone density measurement. And when you get a DEXA score, you should get a segmental DEXA score. They measure the hip and the vertebrae. And some people go, I don't know why they just check those two things. Well, that's because that's where most fractures occur. In fact, most fractures occur in I think 75% are in the vertebral compression fractures. And a lot of times they're clinically silent. You don't even know that they're there. And sometimes they're super painful. And you absolutely know that they're there. So anyway, back to the DEXA scan. So the DEXA scan, painless, simple, 10 minutes, not expensive as far as scans go, imaging. Most insurance companies and because insurance companies tend to follow guidelines, recommend you should get your first DEXA scan at the age of 65 if you're a woman, and 70 if you're a man. I kind of disagree with that. I'm going against the grain here. I think you should measure to know what your baseline is. And so now there are caveats here. So if you have a lot of risk factors, getting one earlier, it may or may not be covered. But again, this is not an expensive test. You can pay cash and just have this done. And I do recommend that, especially if you've gone through early menopause or have a lot of risk factors. Anyway, so you get your test back, and you've got a DEXA scan report, and it has a T-score and a Z-score, and you see a bunch of numbers, and you're like, I don't know what this means. Well, the T-score is you versus a normal 30-year-old person, healthy 30-year-old bone, where you are in relation to a bell-shaped curve. And my next slide kind of gives you a visual so you can understand this, but it's not a bell-shaped curve. But you remember the old bell-shaped curve from statistics, and 0 is the middle. It's the median. It's pretty much average compared to a 30-year-old. And so one standard deviation above would be better, and one standard deviation below would be less. And so there is, again, a continuum, and then 2 standard deviations, and so on and so forth. So that's your T-score. Z-score is the same thing, but it's not comparing you to other 30-year-olds if you're 65. Z-score is comparing you to same age peers. And so that's sort of where you are with your same peer group. But osteoporosis and osteopenia is based on the T-score. You can also order a vertebral fracture assessment. I say you, but your physician can order a vertebral fracture assessment to look for those microfractures that you might not know that you have. That's not always necessary, but it's another way to kind of check for quality, not just quantity of bone density. there is a computation called a FRAC score. It was developed in 2007 by the World Health Organization as a fracture assessment tool. And you can find it online if you just Google it. And it takes into account other risk factors because it's not all about bone density. It sounds like it is, but it's actually bone density is quantity, but there's also a quality piece here. Like you're turning over bone, but what you're replacing with it, is it good quality bone? And how do you even look at that? So the FRAC score doesn't tell you about the quality, but it does factor in risk factors, body mass index, medications, family history. So you don't treat somebody just based on a T-score. You can, and a lot of people do. And so if your T-score is really bad, like -3, or you've had a fracture, you're going to have to consider some medications to get you out of the hole. But we're not tackling that subject today specifically. We're talking more about bone health. To the right is biomarkers. Well, there's several different biomarkers that you can give you a look to see, well, could you be turning over bone even if your bone mineral density is normal or normal low? Like, are you really cranking through the remodeling states, and are you building too much? Or there's a lot of factors that can be looked at in people where it's less clear. So N-teleopeptide is something we measure in the urine. It is a metabolite of collagen breakdown. So if you've got a lot of that in your urine, which we see a lot when people are really inflamed and have a lot of oxidative stress, it means you're starting to break down a lot of your osteoclast. Remember, those are the ones that break you down, are very active. You're turning over a lot of collagen. Now, collagen is also in your skin, hair, and nails. So, those are at play as well. Vitamin D levels, super important. Calcium levels in a serum calcium. Serum calcium is pretty tightly regulated, so you don't know where that serum calcium is coming from, but it's good to know, is it too low? Parathyroid hormone. Some people have issues with that as a separate diagnosis. Osteoclastin measures the activity of the osteoblast, like how active they are. Outphos comes from different tissues. It comes from gut. It comes from bone primarily. And you can fractionate that. You don't have to get fancy with all these for just regular things, but you can get a lot of information just from regular labs like a CRP and A1C, which has to do with blood sugar. There's a lot of other markers that you can kind of look at to see, where is this person's risk? What is their overall health? And then, of course, height. I didn't think I mentioned that, but loss of height, it would be another red flag, like, oh, there's something going on here. So here is a slide that looks at sort of, it's not a bell-shaped curve visually, but you kind of get the picture if you remember what a bell-shaped curve looks like. And a normal is -1 all the way up. Most people fall between -1 and +1, but there's also some caveats there. Osteopenia would be a T-score of -1 down to -2.5, but -2.5 and greater is osteoporosis. And the bigger the negative number, the worse you are. So this is a little repetitive, so I will go through this quickly, but the factors that affect bone health are diet, activity, family history, hormones, nutrients, minerals, and lifestyle choices. And you'll see on this slide a lot of the different things that we've already talked about. So I'm not going to break this down in this moment because, like I said, it's sort of like a review of what I've already said. We're going to get into more detail here. Okay, so what's the lead things that most people think about when they think of bones? They think calcium, vitamin D, they might think of magnesium, they might think of vitamin K, they might think of collagen or protein. So we're going to go through each one of these very specifically. starting with calcium. And I list on these slides the food sources first, because I think food needs to be first. Before we think of a supplement, we need to think of food, and we need to think of our gut, and is it healthy, and are we digesting our food? Are we absorbing our nutrients? Where are our deficiencies? And that's where you can look and see, how is my diet shaping up? And when I think of calcium, most people think of dairy. Well, around here, we have a lot of people who don't need to do dairy for lots of reasons, or they have lactose intolerance or inflammatory conditions. Anyway, so people that are vegetarian or vegan and they're not getting dairy sources, calcium can come from other things. You don't have to get it from dairy. But there's a lot at play here. So the food sources, there's just a few listed, but I'm not going to read those because you can read. And then there's all kinds of calcium supplements, just to completely confuse everybody. There's calcium carbonate, there's calcium citrate, calcium microcrystalline, hydroxyapatite complex. And that is actually my favorite, because that is actually what is most representative of what your bone is mineralized with. But again, remember, food first. Elemental calcium per day recommendations are about 1,000 to 1,200 milligrams per day, and that's food plus supplements, not just in supplements. And again, these are not person specific, so these are just general recommendations. And a serving of dairy, as an example, has about 300 milligrams per serving, and then the other foods tend to have less, 100 to 200 milligrams per serving. It's best not to exceed 1,000 milligrams per day in supplemental calcium, because there is some risk associated with that. There's been some increased concern about heart disease associated with supplemental calcium, meaning causing calcifications in your arteries. Interestingly, dairy does not increase dairy lowers your cardiovascular health risk. But again, we're not talking about dairy as a thing. People say, well, what about me? I have kidney stones. I don't want to supplement with calcium, and caution should be advised. But not necessarily in relation to food. I'm talking about supplemental. So when you're supplementing, you do need to look at the label, and you look for the amount of elemental calcium per supplement. As an example, calcium carbonate is about 40% of elemental calcium. But it's best to take supplemental calcium in divided doses. Don't take it all in one big handful if your dose of supplemental calcium is going to be over 500 milligrams. But again, I really want you to focus on food. Of the choices listed here, calcium carbonate is probably the worst one that I would not choose. It's poorly absorbed. It is the cheapest, but it has to be taken with meals because it's stomach acid dependent on absorption. So if you've got low stomach acid because you're stressed, or you're on a PPI, or any other number of things, you're not going to be absorbing it. So you're kind of wasting your money, and there can be some contamination. So I would steer clear of that one. All calcium supplementation can interfere with thyroid medicines and iron supplementation. It interferes with absorption. So be cautious there. And of course, I need to mention that if you're pregnant, you need higher levels of calcium. And again, we're not talking about specific people here, just in general. These are general recommendations. Next up is vitamin D. So let me get my slide. So vitamin D sources: eggs, salmon, tuna, sardines, dairy, and mushrooms, and sunshine. So sunshine is great if you live pretty much north of Atlanta. But that's wrong. If you live south of Atlanta, but north of Atlanta, you have an increased risk of not. And if you're inside, if you have a job where you're just inside all the time, you don't like being out in the sun, you're fair skinned, you burn, you're always slathered up with sunscreen, you're not making a whole lot of vitamin D. Vitamin D is made in your skin, but you have to have about 10 to 20 minutes of sun on your skin between 10 and 2 without sunscreen. Obviously, you don't want to burn because that goes against common sense, but and there is some genetic role with vitamin D. Vitamin D, some people have a hard time getting their vitamin D levels up and they're chronically low, and that has a lot to do with genetics. And so you don't have to know your genetics, but you should know your vitamin D level. And so I do recommend that you test and don't guess. Vitamin D, if you're supplementing, you need vitamin D3, and ideally combined with vitamin K2, especially if you're over the age of 50, because K2 helps keep the calcium out of soft tissue, such as your arteries, and keeps it more in your bones where it needs to be. Magnesium is next on our list. Again, food sources on the left, dark leafy greens, beans. You'll notice there's some repeat players here. So there's starting to be a theme of which types of foods are really good for bone health. Supplements, there's a ton of different magnesium supplements. There's magnesium gluconate, malate, sorbate, glycinate, threonate, and they all have different roles. I'm not going to dig into that deeply, but it is good for bones. Magnesium is one of the most important nutrients in the body. It's involved in over 300 metabolic processes, and it's common deficiency. And deficiency of magnesium reduces the osteoblast, remember B for build, formation, increases osteoclast formation. So low magnesium can contribute to low serum calcium because it is important in absorption there, as is the vitamin D. So if you're having your magnesium measured, it's best to measure the whole blood in the red blood cells and not just a serum magnesium, because it's not an adequate representation of your magnesium stores. Daily recommendation there is about 600 to 750 milligrams a day. And there is some literature that suggests a calcium to magnesium ratio of 2 to 1. Next on our list is, let me go back, is vitamin K. Vitamin K, again, is important for lots of things. It's involved in blood clotting and blood formation, and K and D work together to modulate calcium balance. Vitamin D helps the absorption of calcium, and vitamin K prevents the loss of calcium in the urine, and again, prevents calcification in soft tissues. So the minimum for just general health is 1 milligram per day for general support, but optimal intake for bone health is closer to 45 milligrams a day of K2. There is a K1, K2, and then there is some literature out there about MK7, which is a superior supplement form of K2. Caution with people on blood thinners, specifically Coumadin. It affects blood clotting. You have to be careful. You can't just go about the vitamin K without oversight there. The other things on this list don't have their own slide because they don't play as big of a role, but I don't want to minimize their importance. Protein, hormones, which we're going to talk about in a minute, weight-bearing exercises, keeping your inflammation low, gut health, weight management. The protein and collagen I want to spend a little bit of time on because most people don't get enough protein in their diet. The RDA recommends 0.8 grams to 1.2 grams per kilogram, depending on your activity level and your body build. I think that's woefully inadequate. It's really closer to 1 gram per pound of lean body mass. If you like percentages, protein needs to be about 30% of your caloric intake. Again, this is not individualized. These are just big blanket statements. So everybody has different needs, but most of us need much more protein than we're getting. Doesn't have to be from an animal source. Protein is important for building muscles, and building muscles is important for healthy bones. So that said, I'm just going to move on from there. Collagen, a lot of people are taking collagen supplements. There is some data that supports that. how it's absorbed from your gut. There's a little question about that, but it's also another protein source. So that's another benefit. Again, weight management, we already talked about. Gut health, we talked about. And then lowering your inflammation is huge. Supporting roles, these are other things that if you're reading about bone health, are going to come up. And I'm not going to go into a lot of detail here. I'm going to give you a couple of lines about each one of them. You don't need to supplement with phosphorus because our diet in America is plentiful of phosphorus. Boron helps increase estrogen levels. So if you have a estrogen-dependent cancer, you need to not supplement with boron. But there's a lot of good food sources: grapes, nuts, beans, vegetables, apples. Potassium, it helps lower the calcium loss in urine. So when people who are very acidic from eating a processed diet, potassium helps lower your helps raise your pH of your urine, and then you get less calcium loss in the urine. But I don't recommend people supplement with potassium. I recommend they eat lots of vegetables and less processed food. Manganese comes from beans, nuts, seeds, greens, whole grains. Silica is actually how collagen is made. It's a trace mineral support, and it is important in developing the strong cross links of the collagen fiber itself. We actually have a supplement here at the clinic called Regenew Plus, and it is a silica supplement, and it helps not only with bones, but hair, skin, and nails. Omega-3s help lower inflammation. Think fish, flax seeds. Vitamin A supports osteoblast activities, but be cautious with high doses because it can suppress bone growth. Zinc is a common deficient mineral, especially in people who overexercise or overdrink. It helps the conversion of T4 to T3, so it helps your thyroid, and it helps with in conjunction with vitamin C to cross-link the collagen fibers. Vitamin C is an antioxidant. It helps maintain collagen fiber structural integrity. So now that your head is spinning, let's talk about estrogen. So estrogen is the single most important hormone that regulates bone mineral density. Testosterone plays a role here, but keep in mind that estrogen comes from testosterone. So when women's estrogen drops off, their risk goes up. So why not just treat everybody with estrogen? Well, the Women's Health Initiative created some problems, and they said, no, estrogen is risky for breast cancer and yada, yada, and cardiovascular disease, and we're just not going to make that a recommendation. And that stands to this day. There's a lot of caveats to that. So I will not make a broad statement of it's good, it's bad, but I'll tell you that you do lose less bone if you have some estrogen on board. That has to be an individualized decision between you and your clinician, but it's worth a discussion, especially if you are just going through menopause. Now, if you're 75 and you did menopause 20 years ago, not necessarily what I would choose. There's some increased cardiovascular risk there if you're starting out 20 years out. Diet, as you saw on my other slides, lots and lots and lots of vegetables, color, beans, nuts, seeds, a lot of opportunity there. Decreasing inflammation, which those dietary things do. Minerals, important. Gut health, digestion, absorption, super important. So if you're having gut problems and you're not getting the nutrients in that you need to, either or, that can be a huge problem and put you at risk for osteoporosis. Stress. How would stress bother your bones? Well, stress, mental stress, creates an oxidative state. In other words, people have higher cortisol levels. Those cortisol levels decrease the sex hormone, so you decrease your estrogen when your cortisol is high. So being relaxed is better for all the reasons. Okay, what about exercise? Well, weight-bearing exercise is key. Bands, weights. If you're new to exercise and you don't know how to lift weights, I recommend getting a trainer just for 1 or 2 sessions to show you the proper technique, because you don't want to go at it at the wrong way and injure a shoulder and cause, or knee, or cause some other problems. What about whole body vibration plates? There is good data on that. In fact, Dr. Licky here at the clinic has one in his office. I can't tell you the amount of time. I can't tell you the hertz. What I found in the literature is mostly around 30 hertz. And the times are all over the place. So just, I think consistency and doing it regularly is what is important. It has additional benefits beyond just building bone or turning on the osteoblast. It also helps with balance, because you're vibrating and you got to use your core strength to stay upright. So that's important. It also helps boost your immune system and decrease your inflammation. What about jumping? Well, jumping is a great idea, but if you have severe osteoporosis, you might not need to jump, because you can get a compression fracture. But there are the little mini trampolines, or some people call them rebounders. There are some data on that, mostly in veterans that have had some injury and they're trying to rehab their bones. And then balance training. This is like the simplest thing in the world. Practicing standing on one foot while you brush your teeth, and then alternating feet. Doing things to improve your overall balance is key, because it's not going to improve your bone quality or quantity, but your bones just don't crumble. You usually have to have something that has caused them to fracture. Now, the worse your bone density is, the more likely you are to fracture something. But sometimes it's just falling on carpet. Well, what caused you to fall? Well, you tripped over, there was a cord in the way. Your balance is terrible. So really having somebody assess your balance. And I do happen to know that most insurances, if you have a diagnosis of osteopenia or osteoporosis, most, I don't know all, will cover a physical therapy evaluation for balance training and strength training. Doesn't mean you can go there as a trainer, but they can show you some things to do. So anything you can do to increase your balance is key. And that has not just to do with your core strength, but also to do with how your feet touch the floor and how your proprioception is. So those all things are super important and should be discussed with your provider. Okay, so I put this, we're coming to the end. I'm sorry this has been long, so I hope your head is not spinning, but I put this picture in. I didn't take it. It's just something I found online, but it reminds me of balance. And when I had the opportunity years ago to go to Paris for the first time, and I saw several little old ladies and men carrying little bags, cotton bags of groceries from the market, walking with a cane, not a walker, on cobblestone streets. And they were just getting it across the streets. And I was like, I can tell they have some osteoporosis, because they're all hunched and they look to be about 90 years old. But goodness gracious, their balance is amazing. And it occurred to me that was probably because those are the streets that they walk on every day. And so they're used to that proprioception, that their body, their brain and body and muscles have adapted to an uneven pavement. Here in the States, everything is paved. We put rails up, everything, and that's good. But practicing your balance, like as if you had a cobblestone street, could be extremely beneficial. Or better yet, go to Paris. Okay, these are some supplements that we have at Maxwell Clinic that I frequently recommend. These are sort of our core supplements that we use. And again, you don't have to take all these supplemental things. I really want to just make some summary statements and then let you go. So here are my summary statements. Don't get all tangled up in the minutia presented here. I have said a lot of words. I have recommended a lot of supplements. But bottom line is, I'm just telling you about the nutrients and what purpose they serve in the body, so that you understand, oh, I am taking this vitamin D, and vitamin D does other things than just bone, but I'm taking it so that it helps my gut absorb the calcium that I'm taking in and deposit it in the bones. Because if people understand what they're doing, they're more likely to do it. But don't get tangled up in the minutia. pull back and look at the big picture. Assess, like, think about your bone health for yourself and your kids. If I've done nothing else today other than to go, wow, I got to think about my bones. This is really important stuff. Then I have achieved my goal, especially for your kids. I wish I had known this when my kids were little. I didn't. I did not know. I had gone to medical school, and yet I missed this global message, that the bone health starts really early, and you got to get them active. You got to get them out in the sunshine, in nature, with some vitamin D being made by sunshine on their skin, and get them eating the good things. And that's can be such a challenge these days. And where can you improve? Like, I've said a lot of things, but where can you improve? To talk to your clinician about this, evaluate your risk. And then measure with a DEXA scan or a vertebral assessment, which goes with the DEXA scan if that is necessary. Eat well and move daily, add weights, and relax and enjoy the journey, because life is very short. All right, I'm going to pause here or stop here and see if I have any questions. I'm also going to look, hold on, and see if okay. I'm looking at the comments. And when I ask who was here and why they were here, we have somebody saying, I was just diagnosed with osteoporosis. I will be taking an anastrozole for 5 years due to cancer diagnosis, and osteoporosis runs in family. Absolutely need this information. I have osteoporosis and do not want to do the Prolia shot, one of the medications. And then we have somebody that says, I have osteopenia, osteoporosis, and fell and broke my pelvis in 3 places in July and fractured T12 8 years ago. So I'm so glad you guys were here. This is kind of like a bucket of information. There's a lot of details. There's a lot of finessing of what you specifically can do. And this is not individualized. This was just a broad swath of all the information. But what I've presented has good data and is worth talking to your clinician about. And I would say on these things, you can measure them, see what your inflammation is, see what your vitamin D is, and try to go from there. Let's see, I have questions. How do you keep building bone? How do you keep the bone building and turnover working after menopause and your hormone levels are either too low or significant non-existent? Hormone replacement is not an option after 60-ish. I think the hormone option is very individualized. Again, if you're well past menopause, you have to proceed very cautiously, if at all, with hormone replacement. And so doing the bone building and turnover work, creating that nice combination is keeping your inflammation down, keeping your diet healthy with all the nutrients that kept being repeated, leafy greens, beans on the slide, and then measuring those things to see where you are. How are your osteoblasts working? How are your osteoclasts working? Because they're not direct measurements, but they can give you an idea of where things may. Weightlifting. A lot of people say, oh, well, I run. Interestingly, runners don't tend to have the highest bone density. You would think so because they pound the pavement, but runners tend to be a lot thinner. I'm not encouraging weight gain, but I am encouraging muscle gain. So I think muscle gain, looking into a whole body vibration plate, and doing that regularly. And so those are my recommendations. If you can't do estrogen, or that's not appropriate for you for whatever reason, and then looking into some of the supplements, the silica that we have with the Regenew Plus is excellent. Has the nice side effect of improving hair, skin, and nails. And so, in addition to bones. Let's see. What do you do at your clinic to help bone health? How do you help osteoblasts to work? So the question is, how do you help the osteoblasts to work at peak efficiency? pretty much all the things that we talked about in the thing. You've got to give them the right nutrients, and you have to, the blast respond to stressors. So if you think about your muscles being attached by tendons to the bone, and to move a bone or a joint, you've got to contract your muscle. So if you put muscle stress on the bone, it sends signals by the osteoblast to say, hey, we're building bone here. Let's kick up the action. And so it's that stress. And so that's why I keep going back to weightlifting, resistant training, walking around with, this is interesting. My husband has recently been interested in rucking. Rucking is where you put weighted, weights in a backpack. Now, don't just everybody go out and do this, because everybody's different, but it doesn't have to be big weights, but just adding body weight and hiking, walking around with additional body weight. I guess you could do ankle weights. If you have severe osteoporosis, you need to be cautious. But again, I'm making global statements, not specific advice to certain people. Other questions? We're almost at the end of time here. The magnesium oxide is kind of somebody said, why do you caution about magnesium oxide supplement? I'm not cautioning people, but it's kind of the junkiest magnesium out there on the market. It's the cheapest. It's what's in, milk of magnesia. So it will give you the runs if you have too much of it. But it's not a good quality magnesium. So you might want to look at other magnesiums. Do I recommend OsteoStrong? I knew this was going to be a question. And I don't know how to answer it, because I really feel conflicted about the data. A lot of the studies that are referenced by OsteoStrong were studies that the owners of OsteoStrong did. So that makes me a little look at it with a side eye. And OsteoStrong, for those of you who don't know, is a company. It's a franchise that men can go in, and they advertise that in 5 to 7 minutes a week, you can activate your osteoblast and build bone. Maybe, I don't know. I because exercise is my passion, and I like going to the gym and I like lifting weights. I just don't see that you can do the same thing in that short amount of time. And it's basically isocentric force on the muscles. So it is a stress. So I can see where it would work. But again, I'd like to see more studies there. It's also, a membership model. So you have to pay and you have to go. And I don't know. I'm not saying don't do it. I'm not saying do it. I'm kind of neutral. I'm not going to pick a side here. I think I'd like to see more data is what I'd like to see. And does yoga count as weight bearing? It compared to not doing anything, yes. And it depends on the type of yoga. I mean, if you're doing restorative yoga, which I am all for, where you're just relaxing and breathing, that's awesome. But no, not so much. That's not really count as much weight bearing beyond your own body weight. And so there's other more strenuous types of yoga that you're doing, certain posturing and thing, but, certain postures and stances. I would caution you about headstands or handstands if you're at an increased risk of fracture, but that could be, so that's less good. I'm talking about added body weight. When you look at, there was a study that I looked at in regards to the best exercise and, the people participating in different exercises, and like mixed martial arts was up there, which, I don't recommend that we all go practice mixed martial arts, and actually football, because it's the impact on the bone. And so you're like, well, you're telling us to be careful, but you're also telling us to exercise. I'm saying exercise wisely, hiking with a little extra weight. That's awesome. Adding a 50-pound backpack, if you've never hiked, probably not awesome. You got to build up to it. So I hope I've answered the questions, and I think it is, last slide. I think it is time for us to end. I appreciate everybody being here, and I hope you learned something, and I hope you share this information with those that you love, because nobody wants to be frail. We want to be strong. Have a good day. Bye.